This is Duke University.
On behalf of Fuqua, we welcome you and thank you for joining us. I'm Manisha Bhattacharya, a 2013 Fuqua alumna and current medical student at Duke University.
And my name is Mike Dombeck, a 2003 Fuqua alumnus and the current chair of Fuqua's Healthcare Alumni Advisory Board. We'd like to welcome Professor David Ridley today. David is faculty director of Fuqua's Health Sector Management, HSM program. He's also a member of Fuqua's strategy faculty and an alumnus of Duke. He received his PhD in economics from Duke in 2001, and as all of you know, he also wrote the paper which became the Priority Review Voucher we're here to discuss today, with co-authors Jeff Moe and Henry Grabowski.
We appreciate the questions you sent us, and we welcome more questions. Tweet your questions to #Fuqua alumni. David, could you remind us of how the Priority Review Voucher became law?
Absolutely. So as Michael said, this was research with Jeff Moe and Henry Grabowski. We presented the idea at some conferences in 2004 and 2005. In 2006, we published the paper, and we had the good fortune that the journal publishing the paper held a press conference at the National Press Club. I presented the paper there, and afterward a reporter said, Senator Brownback would like this, and he did. He got some teammates, Senator Brown, Senator Lieberman. They made it law in 2007. The FDA finished the regulations in 2008. In 2012, it was amended when the Prescription Drug User Fee Act was reauthorized to include rare pediatric diseases as well as the previous neglected diseases.
And can you remind us how the mechanism works? Any updates?
So first of all, the mechanism, and then I'll give you some updates. So those of you who watch the video know the mechanism. But you might not know all the updates because some interesting things have happened in the past 2 weeks. So first of all, the mechanism. If you develop a drug for a neglected disease, and there's a list of these 16 neglected tropical diseases. Neglected diseases are diseases that a lot of people suffer from, but those patients are typically poor and don't have a lot of money to pay for the drugs. So we have vouchers for the neglected diseases, and as I said, there's also vouchers that can be awarded for rare pediatric diseases. Okay, so if you develop a drug for one of those diseases, and it gets approved, and it has priority review, so the FDA thinks it's sufficiently important and novel to get priority review on its own merits, the manufacturer gets a bonus priority review, and they can sell it. So a little biotech company can't necessarily use that bonus priority review for itself, but it can sell it to another company and get through FDA review faster. Okay, and updates, you said. So what's new? What's happened in the past couple of weeks? So on Valentine's Day, the first voucher was awarded for the developer of a rare pediatric disease. This disease is Morquio A from BioMarin. And so they have won a voucher in the last couple of weeks. Another update is that a week ago, the president renewed the Patents for Humanity program. Patents for Humanity is a program at the Patent Office inspired by the Priority Review Voucher. The president renewed that program as a pilot program. That's a program inspired, as I said, by the voucher. Our neighbors over at law, Artie Rye, when she was in the White House, now on the Duke faculty, she suggested taking the program to the Patent Office. And Ed Elliott and others made that happen. So it's been a fun couple weeks.
Absolutely.
Great. And just for clarification for everyone, how many vouchers have been issued so far?
So there have been 3. So the third was on Valentine's Day for the rare pediatric cancer. And prior to that, there was a malaria drug and a tuberculosis drug. And our hope is that later this spring, we'll see a leishmaniasis drug.
Great. So one of the questions you received was about the vouchers and how to shop for them. So what's the best source of information a pharma company interested in shopping for the vouchers can use to learn about which companies currently own them?
So the developer of the malaria drug that won a voucher used their voucher. However, the TB drug and the Morquio A drug, those vouchers have not been used. And there's also an expectation that the leishmaniasis drugs voucher will be available, assuming it's approved. So there are 2 vouchers out there now, could be a third one coming. What's the best source of information? I'd have to plug my own website. So Priority Review Voucher.org, not .com, .org. PriorityReviewVoucher.org. I try to keep that updated with the latest information.
It sounds like there's just been a few, but how would someone figure out what the average selling price of the Priority Review Voucher is?
We are all very interested in that question. And in fact, investors in the company that has the leishmaniasis drug are very interested in that question because the value of that company is very much tied to the value of that voucher that they might sell. This is the $200 million question, and we don't know yet. And we're really eager for one of these vouchers to be sold to establish a value in the marketplace because right now there's uncertainty about the value. And because we're risk averse, people are risk averse, firms to a great extent are risk averse, that uncertainty leads to slightly lower valuation, slightly less enthusiasm for the voucher. And so we hope to get some prices out there. We have estimates in our research, but there hasn't been a price established in the market yet. I sure hope J&J, BioMarin, sell your voucher and let us know what the price is, please.
That actually, David, tees up a question we got from Oscar, class of 2012. And Oscar asked, how do we incorporate that uncertainty and that risk surrounding the valuation of the vouchers? What are some of the things like the risk of rejection of the application or what are some of the other risk factors that a buyer might discount the value of the voucher by?
There's certainly uncertainty. So, and you mentioned a couple of those sources of uncertainty. We're not sure exactly what the value of the voucher is. We're not even sure that the drug that's using the voucher will get approved. So I believe on average, so the average drug that makes it through phase 3 and sends its application into the Food and Drug Administration, I think the approval probability is about 70 or 80%. Actually, you might know this better than me, Michael. So Michael's an executive in the pharmaceutical industry. He knows a lot about R&D. But my understanding is your approval probability for your average drug is about 70 or 80%. My hope is that it's higher for the drug that uses a voucher because that voucher should go to drugs that value it the most. That voucher should go to companies that are quite confident that their drug will be approved. Now, if companies don't sell their voucher, if they hold it internally, that may very well not be the case. But if you want more technical details about how we incorporate these probabilities, our 2010 publication in The Lancet, European Medical Journal, I published a paper with Alfonso Calle Sanchez. The AP in the formula is approval probability, so it's in there. So for those of you that enjoy reading medical journals, please check it out. Or perhaps those of you who are curious about the value of it, this might be a useful calculation.
So Craig from Daytime MBA 2009 had a very good follow-up question. In the case that a drug is not approved, do you think the voucher should be returned?
That is a good question from Craig. So on the one hand, that would increase the value of the voucher. A higher value for the voucher would encourage more drugs for neglected and diseases and rare pediatric diseases. So that's good. So in that sense, it makes sense to return your voucher if you don't get approved. However, I do think that it's costly for FDA to give a drug priority review. It costs them extra resources. We estimate that it costs them a couple $1 million. Now that's not a huge amount because we think the voucher is worth a couple orders of magnitude more. So $2 million is not that much compared to $200 million, which is the value of the voucher. But the cost to the FDA is real, and I'm afraid that if the vouchers are refundable, companies will be less careful about what drugs they apply the voucher to, and will sort of unnecessarily burden the FDA. So my inclination is that you not get it back, and that's the policy. You don't get it back if you don't get approved. Although I can definitely see the other side, it would increase the value, but at some cost to FDA. So I'm a good two-handed economist. I see both sides of this.
Craig had another question along line of thinking about the value of the vouchers. Asked an interesting question about where do you see, what sort of company in the industry do you see valuing these vouchers the most? The small startup company, the big pharmas, or someone in the middle, a Biogen IDEC, a Vertex, a company like that?
Another good question. So if you're going to hold it internally, of course, a bigger company is going to value it more because they have more molecules to which to apply it, more choice to find the optimal molecule. Of course, if there's a lively market in the voucher, then we could certainly see a smaller company purchasing it. The voucher is going to be most valuable for a potential blockbuster drug because getting to market is more valuable for a drug that's going to make a lot of money. You want to shift those sales forward. So it needs to be a blockbuster drug that's not too novel, not so novel, not so amazing that it gets priority review on its own merits. So a blockbuster Me Too drug. So a Nexium, right? Nexium's a $5 billion drug, $5 billion a year drug. It's a Me Too. It's not particularly novel, but it's really valuable to get it to market sooner. So, I would associate a blockbuster Me Too drug with a larger company. But I wouldn't think of it so much in terms of what companies would value it as so much as which molecules would value it.
George, who's actually an applicant to Fuqua, wanted to ask you about the price of the drug and the impact of the voucher on the drug. So basically, would a company using a priority review voucher on some other drug increase the price of the drug when it gets approved? And are they paying more to the FDA to use the priority review voucher? Is that a problem?
So I'm going to stop saying it, but great questions. But I'll try to stop saying that now, but they have been fabulous. Thank you to those of you sitting in your questions. So this has been a concern for decades in that we haven't had the priority review voucher for decades, but we've had the Orphan Drug Act for decades. And so we see many examples where a drug for rare diseases benefits from the Orphan Drug Act so that half of its R&D costs are covered by the government through the Orphan Drug Act, and many times the drug company sets a high price on the drug. Why are they able to set a high price on the drug? In part because very few people are using the drug. It's a drug for a rare disease, an orphan disease. So insurers are often willing to pay a high price because it's not a big line item for them. Not a lot of people have the disease. So with orphan diseases, we often see high prices for these drugs, and the company's justifying it, saying we have to recover our R&D costs. So we could see something similar with regard to the priority review voucher. Quick segue, neglected disease drugs and rare pediatric disease drugs are also orphan drugs because very few Americans have these diseases. So they have similar benefits. So this is a well-known problem. And we do see high prices for these orphan drugs, and this has really annoyed Congressman Waxman, who is one of the sponsors of the Orphan Drug Act. He's been quite frustrated that prices have been high. Okay, so what are we going to do about it? There's several approaches. So actually in our original paper, we proposed that if you win a voucher, you give up your patent. And so that allows anyone to make it, and that allows potentially the price to be low if there's a lot of competition. However, that didn't make it into law, and that's actually fine with me. I worry about dampening incentives for developing these if you have to give up your patent. And I worry about whether anybody will make it if you give up your patent. So I'm actually fine with the fact that you don't give up your patent under the law, although that would have been a mechanism for addressing this problem, potentially. Another mechanism for addressing this is in the case of the rare pediatric diseases, which often have high price tags, and not many people using the drug, but high price tags. There's a requirement that you have to report to FDA a few years later about how many people are accessing the drug and what you're doing with the drug. And so there's the potential for publicly shaming a company that charges really high prices for the drug. And thirdly, I think there's an incentive on the part of the manufacturer, especially in the case of the neglected disease drug, to want to make this drug available. Part of the value for a manufacturer of of making a neglected disease drug available is the warm glow you get as a company, and more importantly, perhaps, the warm glow your employees feel. Your employees feel proud of you. If you're helping people suffering from neglected diseases, that's something that your employees can feel proud of. When they're sitting at the around the meal table with their family members, and their family members, your aunt says, "Don't you work for one of those nasty drug companies?" Your response is, "No, I work for a drug company that's helping treat people with these neglected diseases all over the world. It's making these drugs accessible." Merck, for many years, prominently displayed its drug for river blindness, Mectizan, ivermectin. When the CEO of GlaxoSmithKline, Andrew Whitty, was here at Fuqua, he said they want to be involved in these diseases because they want to make their employees proud. It's how they retain and attract top talent. So I think there are a lot of reasons why we can expect that that these drugs will still be accessible. Now, for some of the rare diseases, if the person's insured, the company might charge a high price, but I think it's reasonable to think for a lot of these neglected diseases, the company will want them to be accessible because it'll have real value for the company and really make the employees proud.
Okay.
We got a question from Jorge, a 2012 daytime grad, that's an interesting sort of tweak to this argument. I'm curious, what Jorge asked was, can you envision a scenario where a company would bring one of these neglected disease drugs forward and secure the voucher, potentially secure approval for the drug, but ultimately decide they either don't want to or can't actually launch the drug and make it available? Is that a scenario where they could secure the voucher and not, even though they've developed the drug, not actually make the drug available?
I think that's a reasonable concern from Jorge and others. Again, I think we can publicly shame that company, and I would be eager to publicly shame that company, and encourage them to at least license it to other manufacturers. So, for example, Gilead decided that they couldn't effectively market their HIV drug in developing countries. They've been licensing it to generic manufacturers. They've selected generic manufacturers with whom to partner, and they've licensed it to those. So I think it's important for us to encourage those companies to make those drugs available themselves or license the technology. And I think it's also useful for us to remind them of what value can have for their companies and for their employees to do such good, to do well and to do good.
Do you think that needs to be in the law?
So should it be in the law that there's a requirement on price?
Not just price, but that it needs to go to market.
That it has to be accessed.
Whether it's a licensing.
I would be quite comfortable with that. So I am thinking about how we would enforce that. But I think we have to be specific about what it means for people to have access. But I would be quite comfortable with that. Sure. Although I think public shaming could have a similar end result if we're vigilant about it, and I think we would be.
Okay. All right. So a question from Sue goes back to your 2006 Health Affairs article, in which you gave a valuation estimate of what a sponsor might be willing to pay someone who's holding a priority review voucher. And have you updated those estimates at all? Are there any other estimates you've seen from any other groups?
Yes. So in the 2006 paper, we estimated a value of about $200 to $300 million, and that's based on a top decile drug. So if the voucher is used by a top 10% drug in terms of sales, then the voucher is worth about $200 to $300 million. There have been surveys, so BioVentures for Global Health, some people from BVGH, Rihanna and Andrew and others, surveyed manufacturers about their estimates of the value of the voucher. And estimates range anywhere from nothing, some weren't enthusiastic, up to $500 million, with an average of $100 to $200 million. So, however, still we've not seen this price in the market, and that's why I'd love to see J&J or BioMarin or Paladin, if they get the leishmaniasis voucher, sell it.
David, do you have a view from a buyer's perspective of the voucher? So if one of these companies were to sell their voucher, from a buyer's perspective, what would be the optimal time to buy? looking at the course of drug development, you want to discharge as much risk as possible before you buy, but you want to give yourself enough time to evaluate whether to use the voucher.
Yes. Okay, so Michael, your question is, so you have a potential blockbuster 3 years away or more, and there's a voucher available. Someone's willing to sell it. When do you want to buy that voucher? So if for a larger company with a bigger portfolio, there's a nice option value that if it's not good if this blockbuster fails, I got another blockbuster later. So I'm inclined to purchase relatively early as a big company with the option to use it for multiple drugs and/or the option to resell it. Now we have to be a little careful with resale. The pediatric vouchers can be resold an unlimited number of times. The neglected disease vouchers cannot. So the law says may be transferred. Unfortunately, the FDA lawyer said, may be transferred once. That's not what we meant, but that's what those darn lawyers interpreted as saying. And so the pediatric edition handles that with multiple transfers. So my thought is you might want to buy early, especially the rare pediatric, which you can then just transfer later if it doesn't work out. With the neglected voucher, you can't necessarily buy it and sell it. You can buy an option on it. Now, we have to be thoughtful about when you want to buy an option, why. But that's a path. That's an alternative to multiple sales buying options. So I guess the other question I would have here is having a voucher going to affect your strategy for that blockbuster drug? So you've got a potential blockbuster 3 or 4 years away. Is your strategy going to be any different if you have a voucher versus if you don't? And so if it's going to affect your strategy, that has to be incorporated too. But maybe it's relatively independent. But this is a fascinating question I want to give some more thought to.
And another one along these lines, we've talked a lot about selling the vouchers. What's the mechanism? You and I have talked about the expectation you would auction something like this. Are you required to auction it? Can you do a party-to-party sale and negotiate that? Is there a way to do a risk-sharing agreement and do sort of a partnership around this?
So I said I wasn't going to say it, but great question. So I especially like this question because it could involve my Fuqua colleagues. So we have a lot of people here that have expertise in auction design. So for example, my colleague Leslie Marks was the chief economist at the Federal Communication Commission. So they're interested in auctioning the spectrum and getting the most value for the government for the spectrum and making sure that it goes to those that value it the most and will use it best. So I like auctions, and for several reasons, I think that the value will be higher, the price will be higher for the voucher because more people will be involved, and it'll go to the highest bidder, or maybe second highest bidder in a second price auction, but it'll go to the firm that values it the most. So I would be keen to have an auction, although that's certainly not necessary. It wouldn't surprise me if a voucher holder made a sale without auctioning it. But to those of you holding vouchers, I would say, I would encourage you to auction it. I think you'll get a higher price, and I think you'll do a lot of good because you will establish a value in the market. By establishing that value, you'll reduce uncertainty and encourage more development of treatments for neglected and rare diseases. So voucher holders, do an auction, make more money, and feel like you're doing a good deed because you are.
So generally, how would you gauge the success of both the tropical disease program and the rare pediatric disease program so far? And in that judgment of the success, could you include your perspective on whether you think the valuation should be different for those two different types of vouchers?
Okay. So how's it going and what should the value be? So first of all, the value. I like the rare pediatric disease voucher just a little better, because it was the second one and we had some time to fix some things. So the biggest fix I want for the neglected disease voucher that the rare pediatric voucher has is that voucher, you only have to give FDA 3 months notice, 90 days notice, instead of a year's notice. So you have a better sense of what you have before you go to FDA. And if you have a better sense of what you have, then you're going to get more value from it. So I think that voucher is a little more valuable. And then your first question was, how's it going? I'm very pleased with it. I'm delighted that we've had 3 vouchers awarded, a 4th one on the way. I'm delighted that there's a pipeline of other vouchers, of other voucher candidates. I'm delighted that firms like Nanoviricide have been encouraged to develop a treatment for dengue because of the priority review voucher. So Nanoviricide was going after HIV and flu. Now they're going after dengue. We have no treatments for dengue. Now we might, in part because of the voucher, although some other companies are also going for dengue now too, and we're delighted by that. So there's several companies interested. So I'm delighted. So let's see, the paper was 2006. The law was 2007. FDA finished the regs in 2008. Not everybody heard about it right away. It turns out that people sitting in the ivory tower here at the university don't always get the word out very well. Although we got some help from BioVentures for Global Health and others did a nice job helping us raise awareness. But firms were really becoming aware 2008, 2009. And then if you say clinical trials take 6 years, 4 to 6 years, so 2 years per phase. So anyway, long story short, we should see more and more vouchers awarded in coming years, because there's a lag between awareness of the voucher program and getting through these clinical trials.
That sets up an interesting next question from Tim Cross-Continent. Before we get into that, just want to invite people to submit any additional questions they might have. But Tim asked about some of the other programs that are out there around neglected diseases and orphan diseases. Essentially, how did these various incentive programs or designations or benefits from regulatory agencies interact? Things like neglected diseases, orphan diseases, rare diseases, the various policies, and how can companies leverage all those together? How do they interact?
Good. So I would say there are at least 3 mechanisms for encouraging drugs for neglected diseases. The first and most important, of course, is the priority review voucher, right? But secondly, as you alluded to and as we mentioned earlier, the Orphan Drug Act is an incentive because these diseases have very few Americans suffering from the diseases. And so if there are fewer than 200,000 Americans, then it's an orphan disease. So that's second. So first, priority review voucher. Second, Orphan Drug Act. Third, there are other mechanisms for encouraging R&D for these diseases. So as we know, in the global health community, the Gates Foundation is interested in neglected diseases. The National Institutes of Health is interested in infectious diseases, for example, and provides a lot of funding for these diseases. So there's the potential for grant funding also. And I guess I would add a fourth, which is the potential for those foundations like the Gates Foundation to then purchase the drug once it becomes available. So there are multiple mechanisms for encouraging neglected diseases.
And do you know of any examples where you would potentially try to use one of these things and that would exclude you from taking advantage of any of the others? So I can envision a scenario where you could work with an NGO like the Gates Foundation for funding and capture value from the Priority Review Voucher, Orphan Disease Act, the GAIN Act, and potentially 1 or 2 other things, and literally just stack them.
I think that's a great point. I think there are various mechanisms that you can stack. And I think that's fabulous. That's what we want. We want more treatments for neglected diseases. They're neglected. We want less neglect of these diseases. So I think you make a great point, Michael, about the ability to stack these incentives. And after you add up these incentives, it might make good financial sense to pursue these. I think one reason companies pursue these is because of the warm glow for the company and the employees. But you might not lose money on these diseases either. I'm not saying you're going to get rich from developing these drugs, but you won't necessarily lose money. And maybe, just maybe, a company like Nanoviricides that says it has very low cost of development, they might actually make money.
Great. Do we have any additional questions that have come in? Okay, great.
Well, one other question that we got from Tim was about the marketplace for the vouchers. Basically, if some of them are transferable and they have value, how do you maintain the intent of the voucher system that they're going to be used for priority review of further drugs, as opposed to them becoming their own marketplace where they're traded and the values fluctuating based on ownership?
So this is an interesting question from Tim. So what if someone corners the market on these priority review vouchers, and then we don't get these other drugs getting to market faster? So these potential blockbuster drugs for cholesterol, they go through standard review instead of priority review. So that means we'll have slower access to those potential blockbusters. That's the downside. The upside is that FDA won't have the burden of additional priority review. And the upside is that monopolists often increase the price of things. And that's bad in a lot of markets. But maybe that's, well, from my perspective, maybe that's good in this market, because if they're driving up the price of vouchers, then they're encouraging others to win vouchers. Mm-hmm. And so I like a high price for the voucher, because that encourages the next company to go after that treatment for dengue or that treatment for trypanosomiasis. So in this case, I'm kind of a fan of monopoly.
All right.
Have we seen anything like the priority review voucher in the U.S. expand to Europe, Japan, other significant pharma markets?
We would be absolutely delighted. So, as you know, the Orphan Drug Act started in the United States. Years later, went to Europe and to Japan. So all these countries have Orphan Drug Acts, although slight variations, so some differentiation. We would be delighted. The Lancet paper that I mentioned earlier that I wrote with Alfonso Calle Sanchez, we proposed a voucher for Europe with a twist, so that not only do you get faster regulatory review, but you also get faster reimbursement review. So the government makes a faster decision about what price your drug will be, so you get to market faster. So in the U.S., our focus has been getting to market faster through the regulatory process. This is getting to market faster through regulatory process and through reimbursement. And so we'd be delighted if this would spread. And that would be yet another, you were talking about stacking incentives. Here's another incentive to stack on there.
Great. So this paper that started all of this was from 2006. What law are you going to write next?
So, as you know, at Fuqua, we write laws with great regularity. That's pretty common for faculty to have laws. I mean, that's because we have awesome faculty. You know that, your students. So I would be delighted to work with some members of Congress on some tweaks to the voucher. Make several tweaks, including making the neglected disease voucher more like the pediatric voucher in terms of a shorter notification period. You don't have to notify FDA so far in advance. We'd like to add Chagas to the list. Mm-hmm. In our paper, we mentioned Chagas. It was omitted from the legislation. I think there was a little confusion because there's two trypanosomiasis, the African and American, and one was included and the other wasn't, and that's Chagas. Mm-hmm. And we would also like to have the shaming mechanism, the reporting mechanism. So there are several things. There was one more. So it was the shorter notification period. Oh, the multiple transfers. So we'd also like multiple transfers for the neglected disease voucher. Unfortunately, Senator Brownback is now Governor Brownback. He term limited himself. Senator Brown is now off the health committee. So we need new friends. But we have some ideas about what new friends we might add. And we were in Washington in the fall for a Duke Law Conference and stopped by and talked to some congressional staffers. So look for more legislation from us, because that's what Fuqua faculty do.
We just got a question from Carol, a daytime 82 graduate. Carol asked, with the neglected tropical diseases being expanded to the rare pediatric, do you see the expansion of this same model into other therapeutic areas, say rare cancers?
Good question from Carol. So, yes, this is a mechanism that we could expand. I do want to be careful that there aren't too many vouchers. That sounds ironic because there's only 3 vouchers right now. How can I say there's going to be too many vouchers? But I say there's the potential for too many because R&D takes a while. And we have some in the pipeline. And if we have a lot of vouchers, then the value of any given voucher will be lower. It's supply and demand. So I'm enthusiastic about expanding the mechanism to help more people. I'm enthusiastic about expanding to Europe. I'm enthusiastic about the Patent Office's mechanism, the Patents for Humanity program. I want to be cautious about expanding in other areas because, again, somewhat ironically, I worry a little bit about having too many vouchers. And in fact, the voucher program for rare pediatric diseases has a limit of 3 being awarded. Although after the 3rd one's awarded, you've still got some more time, so there could be more after that. But the 3rd one's awarded, you've got some time, and then we reevaluate the program, in part because we want to make sure that there aren't, quote, too many vouchers.
Great. So one other question about the vouchers. When you think about a company saying, all right, should we go after this program? Should we develop a neglected disease drug and then get a voucher? Do you have any concern about whether the research that they do going forward is novel research versus going back into their compound library, pulling something from the 1970s and saying, oh, maybe this will work? Does it make a difference to you? Do you think it makes a difference to medically in the epidemiology sense of what kind of medicines we're getting?
Yeah, so which drugs deserve a voucher? Which drugs should be awarded a voucher? And do we worry that companies might game the system? Might bring a drug to market just for a voucher without regard to the benefit to society. There are a couple of mechanisms to guard against gaming. We always have to be aware of these incentives. That's what economics is all about, right? So people and firms respond to incentives, so we have to be aware of unintended consequences. So there are a couple of mechanisms to guard against this. One mechanism is that to win a priority review voucher, your drug must have priority review itself. So your malaria drug must be deemed sufficiently important by FDA to get the priority review, to get a bonus priority review. So FDA must think that this is important for people in the US to have access to this drug. Or people, actually shouldn't just say the US, it's important that people in the world have access to this drug. And so you have to get priority review to win a bonus. So if you're gaming it, there is a mechanism by which FDA can call your bluff. Also, this must be a drug that hasn't been approved in the US, so it has to be novel in that sense. So that's another check on it. Although that's maybe a problematic check on it because in some sense, it is unfortunate if there's a molecule that could be repurposed for another disease and really help people. We don't allow that. So that's unfortunate. But again, to try to mitigate some of the gaming you worry about, that's why that's in place. So the fact that FDA has to regard you as priority and the fact that you can't have previously been approved in the US, these are a couple of mechanisms to guard against the gaming, but there is that potential.
We got a follow-up question from Tim, and Tim asked, how are the diseases, how do we classify them as neglected? How do we define what is a neglected disease? What determines that? Is there an opportunity for companies to actually influence that list and say, we'd like to see these diseases, it would be encouraging to us to see these diseases defined as neglected?
So it's nice to get these questions from Tim. It's nice to know that at least one person's watching. So thank you, Tim. And thanks, and I know more people are watching. Thanks very much I know my mom's watching, so thanks very much for joining us, Mom. So which diseases are neglected? Where does the list come from? Can it be amended? So there's a list of 16 neglected diseases in the law, from Bruley ulcer to Yaws. That list can be amended. As I said, we hope that Chagas will be added. There is a mechanism by which Congress can make the change, obviously through legislation, but there is a mechanism through which the Food and Drug Administration can make the change. So you can appeal to the FDA for an expansion of the list. The list is based on drugs that have a large burden around the world. So a lot of people suffer from these diseases. That makes it different from typical orphan disease that a lot of people suffer. They just happen to be outside the US. So neglected is a subset of the larger orphan space because few Americans have it, but a lot of people in developing countries have the disease. So large burden and very few treatment options. There's been some debate about whether HIV should be a neglected disease. Some people say yes, others say no. We say no, it's not eligible for a voucher because although there's tremendous suffering, tremendous need, there is suffering and need in rich countries, and you can make a high price from HIV/AIDS in rich countries. So there's a list of 16 diseases. Check out priorityreviewvoucher.org to see the list, and there is a mechanism for adding diseases.
We got a question from Gavin, a 2013 WEMBA, and it's a sort of a fun question. Where did the idea come from? What was the magic sort of brainstorming aha moment? Gavin's interested in mirroring that and taking it to other industries. So he wants to know, what was the genesis?
I think I know Gavin. So it's nice to hear from Gavin. I had a Gavin in my executive MBA class not too long ago. So Gavin, thanks very much for the question. I hope you are well. So what's the genesis? So the idea is based on another idea that was out there that didn't get much traction. And it was actually an idea that the pharma companies loved, but the insurance companies hated, the generic companies hated, and members of Congress hated, or some members of Congress. So the idea was that if you develop a drug for a neglected disease, you got a voucher for a longer patent life. Why do drug companies love that? Well, imagine if Lipitor, Pfizer's Lipitor, which made $10 billion per year, something like that, anyway, billions of dollars per year. Imagine that if Lipitor got an extra 6 months of patent life. How much is that worth? $5 billion? That's real money. $5 billion. You'd sure want to develop a drug for a neglected disease for a $5 billion prize. That's an awesome prize. But as you can imagine, insurance companies didn't love another 6 months of Lipitor being on patent. Generic companies didn't love it either. Payers didn't love it, including the government, which is paying for drugs through Medicare, Medicaid, and other mechanisms. So, and actually, I don't love that because people suffering from high cholesterol pay higher price longer to help people suffering from malaria. Now, I can see that's not such a terrible transfer to make because I do feel for the people with malaria, and the people with high cholesterol hopefully have good insurance here in the US, but it's still not optimal. I would rather, that's a lose-win. I'd rather create a win-win where you get, this one drug gets to market faster, people get to access it faster, and we get the malaria drug. So I like the win-win better. And so this is why Jeff Moe, Henry Grabowski, and I proposed this. It was a reaction to the proposed voucher for a longer patent life, proposed voucher to keep you on patent longer rather than what our proposal, which was a voucher to get you to market faster.
I think that's it for questions. Great.
Wow, this is
Good.
fun.
Yeah.
So thank you, Manisha. Thank you, Michael. This was great fun, and thank you to both of the people watching out there, and thank you, Mom. And thank you to the multimedia people behind the camera. So have done a fabulous job, and also made that really clever video. So I'm sorry you didn't have a better host for the video, but you had great illustrations in that video. And thank you to our alumni team as well. So this has been great fun. So a couple of announcements. One, for those of you interested in talking more to us, the health sector management faculty, we'll have an executive education opportunity coming up in May. And if you'll Google Fuqua Executive Education, you can see some of our exec ed offerings, including this new HSM offering we're going to have for 3 days in May. Another announcement is that the next of these Fuqua faculty conversations will be with my colleague Ronnie Chatterjee. Ronnie's fabulous. He's in the strategy area with me, in the health area with me. He'll be doing the next one of these. Ronnie's formerly on the Council of Economic Advisors, and he's just a star professor here, and many of you alumni know Ronnie. The title of Ronnie's talk is Rising to the Challenge, Bending the Cost Curve in Healthcare and Education. Healthcare and education are different in some good ways and some bad ways. How can we bend that cost curve? Okay, once again, thank you so much for your great questions and for joining us today, and for the team here at Fuqua. Thank you.
Thank you, David.